My name is Liv Sasaki, and I am the Executive Director at the American Heart Association in Utah. Again, welcome everyone. Thank you for joining us. The American Heart Association and Cambia Health Foundation, who is the corporate foundation funded in part of Regents Health Plans, serving members throughout the Northwest and Utah, have joined forces with the goal to have to really improve overall health and for women and families in our community. So a couple of housekeeping items before we begin. Today's discussion is a webinar format, but we want it to be interactive. So even though we can't see you, we want to hear from you throughout the discussion. Please put your questions, your comments into the chat box. Make sure that you choose everyone from the drop-down menu so we can all see what it is that you're asking or commenting on. And at this time, I'm just going to go ahead and introduce our moderator for today's discussion. We have Maeve McClellan, who is the Director of Engagement and Operations at the Cambia Health Foundation. Maeve's career centers around healthcare transformation to improve equitable outcomes. Previous work has included maternal health research, consulting in practice transformation, value-based pay, quality measurement, safety net systems, and improving immigrant healthcare access. Thank you so much, Maeve, and Cambia Health Foundation for your support of women's heart health. I'll turn it over to you.
Thanks, Liv. It is such a pleasure to be here on behalf of the Cambia Health Foundation, partnered with the American Heart Association to raise awareness of this important topic. The Cambia Health Foundation works across 4 states, Washington, Oregon, Idaho, and Utah. And today's conversation is specialized to our Utah community and will be kicking off a 3-part series focusing on raising awareness of these women's health topics. So this month, we not only celebrated Mother's Day, but it's also Mental Health Awareness Month. And one of the little known facts about cardiovascular risk factors for women is that mental health plays a really important role. One of the areas that the Cambia Health Foundation works in is our Resilient Children and Families area. And this really focuses on how do we deliver the best outcomes for children 0 to age 8 and their caregivers. So maternal health plays a crucial role in our overall strategy to impact this age demographic. With that, we want to move on to focusing on our discussion, particularly postpartum mental health. We have a nice group of women's health experts with us today, and we know that this is a really crucial period in women's health as a whole, and there can be a lot of things going on in addition to the physical follow-up from going through a pregnancy and a birth and caring for a very young human. There can be a lot going on emotionally and mentally as well. So today's conversation is going to be really focused on what does that look like for women? And I think equally important, what can we all do as community members in Utah throughout the greater Northwest to show up for those new moms in our life and help improve those outcomes? So to start off our conversation, we'll talk about what the association is between cardiovascular risk and mental well-being. And then we'll move on to some of those more practical pieces of what can we do to help the new moms in our community. So with that, I want to go ahead and start introducing our panelists. I'd first like to introduce Dr. Lauren Thielen. She is attending today as a maternal fetal medicine specialist. We also have Erin Cole, who is an associate professor up at the U for the nursing school, as well as a midwife with Birth Care Healthcare. We have Ange Leinbach, who is a therapist, as well as the chair of Postpartum International. And we have Julia Iwanowski, who has a background in public health and as well as a therapist. So we'll post full bios in the chat box so you can see the great background that these women are bringing to the call. And with that, I want to go ahead and jump into our first question. So let's start at the beginning. I'm going to point this question to Dr. Thielen. Can you talk a little bit about how postpartum mental health affects cardiovascular health for moms?
Yes. Can you guys still hear me? I think my camera froze for a second.
You sound great.
Okay. Yeah. So the relationship between mental health and cardiovascular health is really complicated, just like everything else about our health. And there are a number of ways that one can affect the other. I think one of the most obvious things that people think about is when you have postpartum depression or anxiety, it can affect your motivation to do things that take some get up and go, like getting outside, exercising, preparing food in your home, things that we know are helpful at preventing cardiovascular disease or managing risk. There's also biochemical, physiological changes that happen with mental health disorders that can plausibly directly affect your cardiovascular health, things like inflammatory changes, inflammatory markers that are higher when we have untreated mental health conditions. And it's also, there are some things that are a little bit harder to understand sort of what comes first, but sort of underlying stressors that can lead to both mental health disorders and cardiovascular disease. Means that we see the two things kind of strongly associated with each other, and sometimes it's hard to know exactly which is causing which.
Got it. So you talked a little bit about kind of the spectrum of different effects and what they might do to impact cardiovascular health. I'm going to turn to Ange for the next question. Ange, can you talk a little bit about what we should be concerned about as we're talking with new moms, maybe as employers, as family members, as friends, that would be something to be concerning that could maybe lead to some of those problems that Dr. Thielen was talking about?
Absolutely. So kind of going back to what Lauren was saying is that everyone is going to be a little bit different in this. But there's a phrase called matrescence, and it's like the process of becoming a mother, and it will go through like the physical, emotional, and hormonal changes that happen. And it's a time, like Lauren said, of transitions, and it can feel like a giant roller coaster, right? Where you're really happy one moment and then so overwhelmed and kind of isolated in another moment. And so some things to watch out for, whether for the good and the bad, right, is feeling like, or sleep is a huge thing. We want to make sure that people are sleeping. So if there's a huge change in sleep or no sleep at all, that's concerning. I typically will ask how many hours are in continuation instead of just the whole night, because that's really important too, is to get that uninterrupted sleep. Appetite and making sure that people are eating is going to be huge. Making sure that some of that personal hygiene is really key. And then there's often like an increase in irritability or rage or sadness that you can watch out for, and a lot of guilt. And just feeling like yourself, right? So like if you were a marathon runner before and now you don't want to get out of bed, like that's a concern. Or if you were got up and got ready every single day and now you don't want to even like talk to anyone, let alone get out of bed or eat or shower, like that's a concern. And then obviously if people are having any thoughts like wishing they hadn't become a parent, any thoughts about self-harm, hurting baby, feeling like they're going crazy, those are some things to really watch out for. And same with the isolation. I think isolation is a really big key component in trying to get through this transition period.
Mm-hmm. I want to follow up a little bit on that piece about isolation, because I think one of the things that can be confusing is you hear a lot about how you should be cocooning your baby and not taking the baby out. You know, when can you kind of tell, is somebody cocooning their baby, or are they really withdrawing to a place that, you know, we should be worried about them?
Yeah, I think that partners play a huge role in this. And I know during COVID times, that was very tricky to play the, like, is it isolation or is it worrisome? But I think partners outreaching, I think having if people can, getting like a little mental health support system in place prior to delivery would be amazing, so that it's like, okay, these are the folks that are going to we're going to outreach to and that are going to check on us, and we're not going to have to worry about like, okay, these are who we trust, they can come over. Also, even if it's just like doorbell ditching to see someone, like doorbell ditching a meal to see someone really quickly, like you can tell a lot. Like if, like I said, if I come to the door and I like look like I haven't showered in 7 days versus I'm normally someone who looks a little more put together, like that's going to be a concern.
Mm-hmm. Okay,
and the joys of technology, you can FaceTime.
That's true. Yeah, there's no hiding anymore. I like it. Those are some good practical tips, I think, on what to look out for. So get your mental health squad together. Partners can play an important role. Kind of be watchful if you're dropping things off. Do people look like themselves, act like themselves? I want to turn to Erin to kind of take that one step further. So we've talked about what some of those signs are that might be concerning. And I think one of the things that could be really overwhelming for a new mom would be kind of admitting that you're having a rough time. So Erin, you're probably one of the first clinicians to diagnose that there might be any kind of mental health struggle in those follow-up visits after birth. Can you talk a little bit about, if you have a patient that you're concerned about, what can a mother expect for next steps in treatment?
Really good question, Maeve. So, I just want to circle back to, in terms of screening, we screen patients, at least in my midwifery practice, we see patients at 2 weeks and 6 weeks postpartum. And then we're also seeing patients inpatient. And sometimes, while we can't necessarily diagnose something inpatient, usually there can be some red flags that occur inpatient when we're just rounding on patients on the postpartum unit, they're still in the hospital. And so people will oftentimes hear warning signs that they're supposed to call their provider about things about bleeding, things about the baby. I always try and include that signs of postpartum mental health issues are as much a warning sign as a fever or bleeding. I want to know about those too. And so making sure that patients know that those are something that we want to hear about. We want them to talk about, that we are a safe, open place for them to talk about. Because I think that's half the battle sometimes, is making sure that patients actually tell us what's really going on for them. So making sure that they know that we are an open place for them to do that. And then in terms of treatment and follow-up, as everyone has already indicated, this is very individualized and involves a conversation with the patient about what's going to be right for them. But ultimately, if someone has screened positive and we've diagnosed them with either postpartum depression or postpartum anxiety, postpartum OCD, there are a number of different disorders that are diagnosable postpartum, we're going to offer them evidence-based treatment options, including medications, therapy, some lifestyle things like Ange brought up, if somebody's a marathon runner and all of a sudden they're not getting any exercise, like exercise can be hugely beneficial for people's mental health. So talking about movement and exercise that's safe to do in the postpartum period while people's bodies are healing. The support network, again, Ange indicated that, and really talking about what is your support network and are you accessing them? And if not, how can we hook you into your support network in a better way? And then mindfulness and meditation. So we'll talk about all these evidence-based options for people. And oftentimes it's a combination of things. Oftentimes there's not a single thing that, makes it all better, but it's oftentimes a combination of things that'll work for people. And again, ultimately, this is an individual decision. And so for a lot of people, they hear medication or they hear therapy or they hear exercise, and that's not for me. So identifying what's going to work for this individual in front of me, this individual mother and family, and how can we set those things in place? So this may involve referrals to people like Julia and Ange for therapy. In terms of medication, we as midwives, Lauren, MFM, OBGYNs, all of us are also an option for starting those medications, because I know that can be a barrier for a lot of patients in terms of a time frame. Oftentimes people, if they need medications, they need them sooner rather than later, not in 6 weeks while waiting to get in to see someone. So we can also get people started on their medications.
Absolutely. So you mentioned a little bit about kind of a range of options. It's always individualized to what works best for that new mom and feels accessible to her. I think one of the pieces in those options that can sometimes be intimidating if you haven't had this kind of help before is seeking behavioral health support with a therapist. And Julia, I know you specialize as a perinatal therapist. So I wanted to kind of turn to you to talk a little bit more about that. Can you paint the picture of what that initial intake process would look like? What should a new mom expect if she's been referred for postpartum mental health concerns?
Yeah, of course. So the therapy treatment is both similar and different from therapy offered for the general population. It's similar in that the therapist will initially do a full assessment to get a better idea of what's going on, what symptoms are coming up, what coping tools, support, sleep, life function looks like. And then, as Erin mentioned, treatment will be tailored accordingly using a variety of therapy modalities based on that presentation. So you might have heard of some of the modalities mentioned, CBT, ACT, DBT, EMDR. It's a lot of acronyms. There might be some grief work. There might be some behavioral activation or group therapy offered. But the therapy treatment is quite different as well. And it's different for a few different reasons. So frequently, even just this morning in a therapy session I had, clients will report something like, I've done things that have been helpful in the past, like getting outside, exercising, listening to music, taking a nap, but I just can't do those things right now. So clients often need support in learning new coping tools because they can't do those. They can't maybe go for a run. They don't have time to take a nap. So the therapy treatment is different because we're often teaching new coping tools. Secondly, the therapy treatment is different because we're primarily focused, at least initially, on symptom reduction. We recognize that parents, we have to function, and we need support with anxiety and depression symptom relief. Oftentimes, perinatal folks are overwhelmed and overstimulated. Our bodies are really unregulated, meaning we're in like fight or flight or survival mode pretty regularly. We're just trying to do our best to get through one day at a time. So our role is to teach tools to help empower folks to regulate their bodies and support their nervous systems so they feel like themselves again, so they can handle life stressors more effectively. And then once we've gone through the symptom reduction and emotion regulation work, then we may be able to dive into other areas that are also contributing to anxiety and depression symptoms. Perhaps there are relationship conflicts or traumatic experiences, thinking errors, grief and loss experiences, co-occurring medical conditions like cardiovascular issues, difficult other life transitions. All these situations frequently arise in the perinatal period. It's a really activating event for both our body and our mind. There are a lot of changes. And so our goal as a perinatal therapist community is to support the whole person and family to navigate this life period as gently as possible. I'll also say that the length of treatment is really different for every person. But what we do know is that every perinatal mood disorder, no matter how strong the symptoms are, is temporary and treatable. As a perinatal therapist, it's really rewarding to work with this population because I know they're going to get better and I can offer that guaranteed hope to my clients as well. And last thing I'll say is that therapy is effective both online and in person. And most perinatal therapists offer both settings because we know that in-person appointments can be really difficult to get to when you have young kids. And we know that telehealth is a really effective form of therapy as well.
Thank you. So I have a couple more questions for our panelists, but I want to invite the audience, if there's something here that has piqued your curiosity or maybe a different question that you've always wanted to know about perinatal mental health or cardiovascular health, go ahead and put it in the chat. And in a couple minutes, we'll move to taking questions from the audience as well. So one question that I want to ask each of the panelists, and that I know as a foundation we've tried to be really mindful of in our Resilient Children and Families work, is looking at inequities for birthing people. We've heard some really horrifying statistics on the health disparities out there. And I know this is something that clinicians are taking really seriously. So I was hoping to kind of hear from each of you. Can you give some perspective on what has come up in your practice or in your professional circles around some of the best practices we're seeing emerge that can help make kind of this birthing period a safer space for all mothers? Let's see. If anyone wants to go first, I'll go ahead. And I think Dr. Thielen, you're at the top of my screen, so I'll start with you.
Yeah, this is a huge problem that I think has come to the forefront in recent years. maternal and perinatal morbidity and mortality is way too high in this country, and it is unequally affecting different populations. And so I think it's a complicated problem and one with no single solution, but a couple of things that I've seen an increase in that I think are helpful. One is the support and encouragement of doula services, particularly for people from underserved medical communities and racial and ethnic minorities, at-risk populations, to ensure, to improve birth outcomes, and then also for offering that support during the perinatal and postpartum period. I'm seeing a shift towards a lot more encouragement and support of doula services in the medical setting, which is great. And then I think another thing is trying to increase access to services, because I think one of the biggest problems is I probably never see a lot of the people who are at highest risk because they don't even have the option to get to me. And so we've been trying to ramp up some of our health services in terms of outreach. So our high risk maternal fetal medicine group does outreach clinics in several rural areas in surrounding states. And then we've also started offering what are called e-consult services, where healthcare providers from outside of the university setting and even community midwives can send us questions about how to manage a pregnancy complication or a health problem, particularly for patients who have trouble accessing, a full in-person visit, or have cost barriers or trust barriers to coming and seeing us in a hospital or clinic setting. So those are two things that I think have been helpful in recent years and that give me some hope that we can try to make things better.
Thank you. All right, let's go to the behavioral health side of things. And can you speak to that?
Yeah, I agree a lot with Lauren that access to care is a huge issue, especially if we look at folks that are in a higher risk population. Right now, if folks have Medicaid, the wait to get into a mental health provider is ridiculous. And at this moment, I would say even it feels very inaccessible. Folks may not have the ability to do a virtual appointment or get to an office, or if they can do a virtual appointment, there's zero privacy. So there's actually no, it's very limited anyways. Also, right. Depending on the population with the multi-generational home, there's a lot of there could be a lot of shame and shame around the need for a mental health. I also think that in Utah specifically, there's a lot of push there's a lot of pressure, I should say, I think, to be this very perfect mother. And I know that is everywhere, but I feel like here we have a very young motherhood population. And sometimes that pressure really builds. And so having people share their stories and know they are not alone in the process is really powerful. And I will say, as Postpartum Support Utah, that is one thing that we try to do, is collect stories and let folks know they're not alone. The Emily Effect is another great agency within Utah that shares stories. There's what's called Stories of Light. Also, there is a maternal mental health resource network through the Department of Health that has a list of perinatal trained providers, doulas, childbirth educators, all of that. And that you can also sort by insurance. But I think our biggest thing is access to care and the wait lists. I will also say that there is a perinatal mental health alliance for people of color, and they are trying really hard to work on closing some of those gaps as well. But access to care is huge.
Thank you. All right, going back to the more physical health side of things, Erin, can you comment on what that's looked like in midwifery as far as looking at kind of what we can do to improve equity in birth outcomes?
Yeah, certainly. A couple of things come to mind that people have already highlighted. The access to care is a huge issue, and the dearth of providers, the dearth of psych mental health providers. So one thing that comes to mind is that I'm doing as an educator. So I'm the program director for our Women's Health Nurse Practitioner program and teach in our nurse midwifery program, is making sure that my students leave our program well-versed in perinatal mental health and treating it with the recognition that they are going to be the first line, and it may take months for someone to get in elsewhere. And so making sure that they're getting training both in medication management, but some basics in behavioral health as well, because they're going to be a starting point. So that helps close that gap. The other thing that comes to mind that our practice is doing, and that midwifery is taking this on, as is NPWH, the National Organization for Nurse Practitioners in Women's Health, is really addressing the fact that we need to have providers from these vulnerable backgrounds as well, so that patients are seeing providers who look like them and understand their experience. And so, again, as an educator, educating students in that and making sure that we're admitting students from diverse backgrounds. And then we also, as a practice, we have several providers of color, and ask a question in our first prenatal visit, in our annual exams, and in our postpartum visits about, we ask two questions actually. One, about whether this individual feels like they've experienced in any healthcare setting, ours or otherwise, any discrimination, or any experiences where their healthcare was not equitable, so that we can address that and make sure that we are providing more equitable healthcare. And then two, we ask patients if they would like to see a provider of color, and then make an arrangement for them to see a provider of color. Again, trying to just narrow that gap, which is so wide right now. So those two things come to mind. And then Ange mentioned, Postpartum Support International and our Utah chapter. One thing that I think Postpartum Support International has done a really nice job of is creating support groups. So they have online support groups, including support groups for a whole variety of populations. There's a support group for individuals of color. There's support groups for LGBTQ parents. Just again, you name it, they've got a support group for it. And I feel like that also is helpful. And again, it's not local, it's online, and there are barriers to that, but it does feel like that's a step in the direction of closing that gap. And then, Lauren mentioned the doula care. So we, as a midwifery practice, have, this is several years ago. In fact, I was a student in school when this started, but a volunteer doula program at the University Hospital. And that, again, providing support for individuals while they're in labor. It may not necessarily be postpartum care, although those programs exist in other states, and we would love to extend our volunteer doula program into a postpartum program. But helping people through the labor process, we know there is an association between traumatic birth experiences and postpartum mood disorders. And so if we can, as a midwifery community, but by providing volunteer doulas, if we can sort of prevent, if possible, those traumatic experiences in the care we provide during the birthing process, we may reduce the risk of postpartum mood disorders. And again, that can close that gap as well.
All right, Julia, is there anything you'd add to what folks have talked about in terms of things that we're doing to kind of promote safer spaces for all moms?
Yeah, the one thing I would add to what I agree with that everyone mentioned, that I've done with a lot of the folks that I'm working with is doing a lot of prep work, doing a lot of prep and planning, and coaching clients to write down questions that come up before their medical appointment. A lot of times medical appointments can be really intimidating when you're with the provider and you get flooded and you forget everything all the questions you had beforehand. So writing down your list of questions beforehand, so that you can come with your list and just read off your list, expecting that you're deserving of time. And so if the provider feels rushed, just trying to be as calm as possible and knowing that you're valuable and your questions are important. I also try to really work with partners, the non-gestational parents, or coach the folks I'm working with to tell their partners that they need their support and advocacy in prenatal appointments and in delivery. A lot of times the patient isn't able to be their own advocate for a variety of reasons in that really vulnerable time. And so they need their partner to step in and know what to say, know how to support, already have practiced, prepped, planned, rehearsed some of that, as well as using your primary nurse as your advocate and trying to have that connection. Because we know that it's a little bit out of our control and it can feel really scary. And when we're in that place of fear and uncertainty, that's when we can be at risk for postpartum mood and anxiety disorders, trauma reactions that kind of linger through that postpartum period. So a lot of the work I'm doing is a lot of prep and planning, being comfortable, being assertive in the medical appointments and in the with the providers that you're working with.
So we got a lot of good tips, I think, from all of our panelists on that. And we're putting some resources in the chat box for some of those programs and pages that were mentioned. We'll also send those in a follow-up email after the webinar. For now, though, I want to follow up a little bit on this theme. We got a question from the audience. Kind of given these inequities, people can have concern about seeing a provider from a different cultural or racial or ethnic background. What advice do you have for somebody in that position?
I can answer that if you want. I think that one of the things that Postpartum Support International does really well is get support coordinators in all of the various states. And it is semi on them. I don't want to throw them all under the bus, but semi on them to kind of know who the providers in the community are, utilize the resources to search, and then help refer folks to potential matches. And so that will be providing, like, knowing who in the community is going to best fit those needs. And also, as Postpartum Support Utah, one of our big goals is to help get providers trained that we are missing, like gaps in services. And so that's one of our goals, as well as to scholarship folks into training to make sure that those are not barriers to care.
Thank you. So I want to follow up a little bit on something that I think Erin alluded to in terms of one of the risk factors for a perinatal mood disorder can be having a traumatic birth. And we know that there's inequities and kind of, who is most affected by traumatic birth. Can you talk a little bit about what you mean by birth trauma and then how that plays into postpartum mental health?
I'd be happy to take that. So absolutely. So with birth trauma, there, if you Google birth trauma, what's going to come up is a whole bunch of lawyers, because the term birth trauma is oftentimes associated with a physical trauma to the baby. But what I'm talking about is the emotional experience of labor and birth and postpartum, and the ways that things can occur that feel unexpected. And I think for many people, I was a midwife before I had my first baby, labor doesn't pan out the way it looks in the movies. It's much longer usually, and it is different than anyone has ever experienced unless they've had a baby before. And so I think the unexpected nature of it can feel traumatic because people aren't prepared for what it's going to look like. And then there are times when things really don't look like what someone anticipated, an emergency C-section or a forceps delivery or too much bleeding afterwards, things that, again, people did not see coming and that no one prepared them for, either in their prenatal visits or in the books they've read. So I think that can lead to trauma when all these unexpected things happen, and people find themselves processing it. I think of a patient who described avoiding the hospital. Her baby ended up in the NICU, and the birth actually was fine, but her baby was in the NICU for quite a while, and the newborn ICU, that is. And that experience was so traumatic for her that when she was driving through Salt Lake, she would avoid going anywhere near the university hospital. And that was a sign to me that she'd experienced significant trauma or post-traumatic. She was having post-traumatic stress related to her experience of her baby being in the newborn ICU. So, this can look like a lot of different things for different people, but what I mean by birth trauma and how that can be related to postpartum mental health or perinatal mental health disorders is that trauma, if it's not processed well, if people just continue to relive the experience, or aren't sleeping because of it, or it's created a lot of fear in them related to the safety of their baby or their own safety, that can lead to depression and anxiety and obsessive behaviors, compulsive behaviors related to obsessions. And all of that can lead to a loss of someone's function in their daily lives, or a change in their function in their daily lives. So that's how those two can be related. And again, our job as birth providers, like people who are attending birth and helping people through their labors, is to try and avoid one, creating that trauma, and two, help people if something traumatic does happen, because sometimes emergency cesarean sections happen, is to then process it with the patients afterwards, talk about it, explain why it happened, make sure that they understand what happened and why, because it can feel very out of control for the person that it's happening to. So yeah, I think a lot of it is about informing patients of what's happening in the moment, if possible, and certainly having a follow-up conversation afterwards. And I have scheduled those conversations when I have been at a labor or birth that has been traumatic. Afterwards, even if it's not a patient that normally sees me in clinic, I have said to the patient, I'd like to talk to you again. Can we set up an appointment, either your 2-week visit, but sometimes that's a little too late, but in 5 days time, a week's time, can we set up a telehealth appointment even, so that we can talk about what just happened when you've had a little time to think about it.
Yeah. Lauren, is there anything you would add to that? You see a lot of high-risk mothers in terms of kind of what you've seen in your practice and how that plays into cardiovascular risk.
Yeah. I think particularly in my practice, people who have certain pregnancy complications or pregnancy outcomes, so preterm birth, preeclampsia, gestational diabetes, these are all associated with having some of those complicated labor courses or birth outcomes, NICU stays, things that are risk factors for, a traumatic experience, and then a lot of stressors in the postpartum period. And then also just sort of underlying sort of physiological risk for cardiovascular disease down the road. In terms of, how to try to mitigate some of that, I think it was mentioned sort of having conversations during prenatal care about what the birth process is going to be like and what the possibilities are. It can be a little bit tricky. I try to personalize it to patients. Some of them really want to talk through every scenario ahead of time, and some of them that's overwhelming or scary to them. And they want to sort of talk about it as it comes up, that it's a possibility for them. So I do try to respect sort of what people's preferences are. Working on labor and delivery, I think an emergency C-section is one of the most traumatic things a person can experience. And I think when it's our job and when we do that every day, it's easy to forget that, to sort of dissociate from it. And it's really important to remember that that's a very scared person, naked on an operating room table, worried about their baby and themselves, and usually alone. So just remembering to be in the moment with that person. And then what Erin said, I think it's ideal if the provider who's there for the event is available to that person afterward. With our, contemporary healthcare practice setups, a lot of times there's group practice settings and people are on call and then they're off or not around. But the nuances of sort of what happened and why and how, I think are best appreciated by the people who were there. And so if at all possible, to have that person who was there be available to follow up with the birthing person later, I think is a great help.
So it sounds like there's some good resources for women, kind of with the original clinician who was there for the birth process. Ange and Julie, I want to turn again to kind of that follow-up side of things. If somebody is struggling with the traumatic birth experience, I kind of have two questions here. One, how do you as a therapist help them process that? And then two, maybe you're a friend, a partner who's listening in and you think this might be affecting the birthing person in your life. Can you talk a little bit about ways that you've seen caring, concerned folks successfully reach out to people who might be experiencing some after effects of birth trauma?
Yeah, sure. To answer the second question first, I would say for the support people around someone who's just given birth, and a gentle reminder that trauma is always in the eye of the beholder. So something that might not be traumatic for one person can be very traumatic for another. So be really sensitive to whatever the person is sharing with you. And then just offer a lot of validation and support. A listening ear is really all the person needs from their support people, the people around them. And so just availability to say, I'm here for you. I want to listen to your story, whatever you're comfortable sharing with me. And so they know that they have that support. So often we're uncomfortable with hard conversations that we want to, put a Band-Aid over it or put some like nice little phrase like, oh, it's okay. And really, we just want to offer that like open-ended support where we just listen to the stories. So that's what you can do as a support person. And then there are a few different options on finding the perinatal therapist. So how to, recommend or refer your friend or family member to a professional to help with that traumatic reaction. So I think we've mentioned a couple. Utah Department of Health has a forum, which I think we included in the chat. Postpartum Support International has a directory list you can find for each state for maternal mental health therapists. Psychology Today is a really popular way to find therapists. And so there's a directory there and you can filter for perinatal issues. And then within the treatment world, what we're going to be, of course, assessing symptoms that are coming up. And then the evidence-based treatment, there are a few different ones that you can go into, but EMDR is really popular and very effective for treating those trauma symptoms. So I would recommend looking for a perinatal therapist who has EMDR training and certification.
Anything that you would add to that, Ange? All right. Well, let's continue. Oh, go ahead. I was going to say, let's continue talking a little bit more about treatment. And I think one of the things that Lauren and Erin mentioned earlier in the discussion is medication is an option. But I think, unfortunately, there's kind of a lot of confusion around what is safe while breastfeeding. Can you talk a little bit more about what some of the resources for women are in terms of medication treatment? Is it safe?
Yes. So I think the short answer is yes, medication is safe. And I always talk to patients about when we are discussing whether to start a medication to treat a health problem, and we are trying to decide whether that treatment is safe, we have to remember that the alternative is not to not have the health problem. The alternative is to have an uncontrolled health problem. And so what we're comparing is what are the risks of medication exposure to the risks of having an uncontrolled health problem. And for the vast majority of health conditions with pregnancy and postpartum, having an uncontrolled health problem is more dangerous for the parent and the baby than the medication would be. And I think research is catching up to framing research studies in that way, so that we're getting better evidence to help guide these conversations where appropriate comparisons are made. There's an appropriate control group when we're comparing treated versus untreated conditions. And I think the other thing that is getting better, we've talked a lot about, access to care, access to providers who are comfortable prescribing medications when they're indicated. And the American College of OBGYN is making a big push to increase the education and comfort that women's health providers have with not just screening and diagnosing mental health conditions, but also with initiating appropriate treatments, not just for, sort of straightforward isolated depression or anxiety symptoms, but also for some more complicated but common conditions like bipolar disorder that people can end up needing help with in the perinatal period that are a little bit more complicated and maybe less familiar for most providers. But making sure that we have good resources so that now that we are more widely screening and capturing people who are in need of mental health resources, that we can then be the initiator of treatment without them needing to jump through more hoops to find another provider.
Perfect. So I want to continue talking a little bit about treatment. I think, Julia, one of the pieces of hopeful information you mentioned was that, typically perinatal mood disorders do get better. Can you talk about how long we typically expect perinatal mood disorders to last and what people should kind of expect in the course of recovery or treatment?
Sure. Yeah. So it's a bit individualized in terms of how long symptoms are going to last. And it has to do a lot with your own coping strategies and support network that you have. I think there are a lot of factors that play into that. Finances is one of them. Is how much access do you have to the services available? And I think one thing that's challenging that I wanted to bring up is the time frame with symptoms that can arise. Is different than I knew before having this training, where we think of postpartum as the first 6 weeks after having a baby, and I think that's when you're given the medical attention from your provider team. But really, what we know is that symptoms can occur anytime within the first year. So symptom onset can happen anytime within the first 12 months after having a baby, with a peak onset around 4 to 6 months. And so that's after typically you're working with your OB midwife team. And so hopefully you're being seen by, your baby's pediatrician or family practice provider and getting that support in those settings as well. And the newest research that just came out in 2020 is actually showing that it's really the first 3 years. So we know it's up to 12 years at this point, but really it's up to 3 years. And I like to say you're postpartum forever. And so really just being mindful of the timeframes there, that if it's been, 18 months and all of a sudden you're noticing these new symptoms of irritability and overwhelm and maybe new trauma reactions and the activation that you didn't fully process in the past 18 months that happened from your birth experience, is reaching out to your provider, getting that referral, reaching out to your support team to get the support there.
Thank you.
Oh, can I add?
Yeah.
Sorry. I also just want to say that perinatal mood and anxiety disorders can also start during pregnancy. And so that is one thing as well to kind of watch for, is people think they hear postpartum depression and think, oh, I'm not sad or whatever, or I'm not postpartum. And so just really recognizing that it can start during pregnancy. And then also just to have extra support built around in that 4 to 6 months period. Oftentimes people are returning to work or breastfeeding is starting to wean, people are starting to wean. And so things to just kind of watch out for and have some extra support around.
That's a really good point. So we're looking at, these could come up during pregnancy. There's that initial postpartum period. There's that return to work milestone for a lot of women and their families, and then that weaning process as well too. We haven't talked much about that piece of things. Like, how does weaning affect mood disorders? What should we be watching out for there?
Can try and answer the question. So again, it's very individualized. For some individuals, weaning is the resolution to their perinatal mood disorder, in that they're sleeping again through the night. They're able to get help from a partner in a different way through the night. So for some individuals, weaning is incredibly helpful for their perinatal mood disorder. For other individuals, it is a trigger. And some of this is hormonal, not entirely clear. I don't know that the science says that it is truly hormonal. I don't know that we have the data to say that. But for some individuals, emotionally, weaning, they really were very tied to breastfeeding. When breastfeeding isn't going well, there is an association between breastfeeding struggles and perinatal mood disorders. And for, I think, a lot of individuals, in my own experience, anecdotally, when they're very tied to breastfeeding, it feels like what they should be doing as a mother, weaning, either out of necessity or forced weaning, can be incredibly challenging and send them into postpartum depression. So it's not clear, which comes first, chicken or egg, and it's very individualized, but there certainly is an association between breastfeeding challenges and perinatal mood disorders. So I think this highlights not only the need for better support for the postpartum period in terms of perinatal mental health, but also in the postpartum period, addressing lactation support, which I think we do a very good job of in the hospital. But there's not a whole lot out there once people leave the hospital. And if there is, it's either private, and again, finances can be a challenge there, or they're hard to get into. We do have outpatient lactation support at the University of Utah in some of the pediatric offices. And I know Intermountain Health Healthcare also has some lactation support associated with their pediatric offices. So it is out there, but it's few and far between. And I think a lot of people don't realize it exists. And so again, those are tied, very, very interlinked, and one can lead to the other. And so, but again, it's very individualized.
And is there anything you want to add to that from the therapist perspective?
Okay. I think that, and Julia can correct me if I'm wrong, but I think one of the things that we do a lot in perinatal therapy is work a lot around like guilt and shame. And just really emphasizing that. It comes up it almost always comes up around breastfeeding or just feeding baby in general. So that's just something to really be aware of as well.
So we're getting close to the end of our hour here. I wanted to close with a question, just kind of backing up and looking at the perinatal landscape from that 10,000-foot view. If there was one thing that you each really wanted new moms to hear, or community members who might be looking out for new moms about how to take care of themselves, what would it be?
I would say if you are wanting to support someone who has recently given birth, just never make the assumption that they're okay because they haven't explicitly said that they need help to you. And just be aware of how common perinatal mood disorders are, and that it's also really common for people not to be open about it or ask for help even if they need it. So being sort of attentive and proactive about it as a support person.
And I would say to anyone who has given birth and to their support people, reminding them to do something for themselves every day, even if it's small. I think we, as new moms, can get caught up in, I just have to take care of the baby. I just have to take care of the baby. and that self-care gets shoved to the wayside, and it is vitally important. For a lot of my patients who love to do particular exercises, all of a sudden being sedentary can be really hard. So I think the thing I would say to people is get outside, walk around the block. Don't forget to do the things that bring you joy. Even if it's small and 5 minutes, do those things for yourself every single day.
I would probably say, and I know it sounds very cliche, but you are not alone. Like, utilize that support system. And support system, if you don't hear from them, I would send them a message and give like 2 options. Like, I'm coming over tomorrow with lunch, or I'm coming over tomorrow for dinner. Like, which one do you prefer, right? Like, I'm bringing this. I also don't feel guilty. I always encourage my clients to charge what we call a baby tax. And it's like, if someone wants to come over and see you, make them do something, like have popsicle sticks with chores written on it, or something that you may need. Like, you can only come over if you bring a pack of diapers, or you vacuum the living room. Like, really utilize that time so that you can either rest or have time with like baby, or identifying yourself with like who you are now as a person.
And I would just echo what Erin said, and everyone. I get outside every day, even if it's just a minute, even if it's just walking out your front door. It helps change your body, helps change what's going on in your brain, just to have a different environment. I love what Ange said. When we're in the throes of it, we're at decision fatigue. We don't have the capacity to make another decision. And so as a helper, as someone in your network, asking how can I help is not helpful. So just decide how you can help and do that. Offer the meal, clean the house, just walk the dog, just offer the helpful tool without asking, how can I help? Or let me know if you need help. That's also not very helpful, because they're not going to let you know if they need help. They'll just do it. And then I would say to the person, the family, trust yourself. If you don't feel like yourself, there's something going on. And so reach out to us. We're here to support you. We want to support you. We're passionate about maternal mental health and creating the best experience possible.
Thank you so much for chiming in on that round robin. I think we've left today with a lot of wonderful tips on how we can better take care of ourselves if you are a new mom, or better support the new moms in our lives. So I'm going to turn it back to Liv to close us out.
Thank you all so much for joining us. And thank you to our incredible panelists for providing such sound advice and awareness and education around maternal health. Thank you to our amazing moderator, Maeve, for really leading this discussion. And of course, to Cambia Health Foundation for allowing us to collaborate in this space and providing this opportunity to come together and discuss this topic. This conversation today is one of many throughout a series in Utah, Idaho, Washington, and Oregon. So keep an eye out for future discussions, and we will make sure to send the recording of today's conversation out to you all. And I just want to thank you again for joining us, and hope you all take care.